Awesome. Welcome to today's Time to Act Substance Use Echo Effects on Children and Families. I'm Leo Vasquez, the project assistant for Project Echo here at the Institute for Disability Research Policy and Practice at Utah State University. If you could, please drop your name and contact information in the chat just so we can stay connected. It really makes it easier for us as well to just share those really good ideas and resources that we have with each other. And if closed captions do help you follow along easier, you can turn them on by selecting the More option in the toolbar and toggling on those captions. We are recording today's echo session for educational and quality improvement purposes. So by participating, you are acknowledging and consenting to the recording. And if you prefer not to be recorded, you may disconnect from the session, but we really do thank you for being here today. Your participation and insights are what make these sessions meaningful, and we hope you'll stay and be part of the conversation. Echo is an interactive community where we like to have our presenters, stakeholders, and community members engaging with one another, whether it be sharing resources or giving recommendations on a case. Participants are also welcome to ask questions. We will have a little Q&A portion for the presenter at the end of the presentation, so if you do have a question pop up, you're welcome to put that in the chat. And case narratives and discussions are a really great way to get support on maybe some of those difficult cases that you may be struggling with, and we can apply those strategies from those breakout rooms to real world problems. So if you haven't presented a case narrative yet, I really urge you to do so, and by just emailing projectscope@usu.edu, and we can get that set up for you. We also do work with sensitive topics, so please remember to protect individual privacy. Again, if you're unsure about a statement or question, you can always reach out to one of our hub members, who should all have an asterisk by their name. And the hub member monitoring today's chat is Janelle Preston, so they can address those concerns or comments, maybe even questions that you may have. And we also have three key components to an echo session. The first is our subject matter expert. So for today, we're having Jill Gresham from Children and Family Futures help us explore the impacts of substance use on families and how we can collaborate as professionals to support families with substance use disorders. Our second key component is our case presentation, which I will be doing for today. And our final component is professional networking. You can always connect with others in the breakout rooms or by reaching out in the chat. Echo sessions are just a really great way to meet colleagues from similar organizations and just share some of those ideas that you may have that maybe others haven't really thought of. And also, let's remember to rename our profiles to our first and last name, our state, job title, and organization. And if you don't know how to do that, you can click on the Participants tab in the bottom toolbar, hover over your name, and select Rename when clicking those three little dots next to Unmute. And this is also just a really helpful function on how to raise your hand. It has moved to the React tab, but it's just a really great way to, if you don't want to interrupt someone if they're speaking, just use the raise hand and we'll get that addressed. And just some really quick notes on echo session etiquette. Let's remember to please use chat or raise hand while the presenter is speaking or if another participant is speaking. And just remember to keep yourself muted if not speaking. And also remember to keep questions brief and on topic so everyone can join in on the conversation. And if you're comfortable, please turn on your camera. It really just helps us feel more connected over Zoom. And how to get credit for attendance by filling out today's survey, which is going to be dropped in the chat today throughout session by Janelle Preston. You can earn a certificate of attendance for participating in our echo session. And many participants actually share these certificates with their employers or supervisors as documentation of ongoing professional learning. So to receive that certificate, make sure to complete the survey that's being dropped throughout chat today. And also, Canvas is the platform we use to put resources from today's session and past sessions for you to access. If you would like an invite to our Canvas page, please email projectscope@usu.edu to access all of those really great resources, presentation slides, and past recordings from this Echo. And just one more quick plug for case studies. They're really your chance for tailored and actionable feedback on a case you may be having some difficulties on. So if you're interested in presenting a case, please reach out to projectscope@usu.edu and we can get that set up. And also, please remember to follow USU's IDRPP Project Echo on social media. We have a Facebook, Instagram, and LinkedIn where we like to post some updates and reminders. We also post some impactful quotes or information from the session. So they're just a really good way to stay connected with one another. And if you'd also like another way to stay connected with this Echo group, you can join our Facebook group by scanning the QR code. If you'd like to more updates on the Echo or just to continue discussions after session, it's just a really great way to do that. So yeah, I'll hand the time over to Jill.
Thank you. Let me just pull my slides up. So excited to be here with you all today. My name is Jill Gresham. I'm a senior manager of the Family Centered Systems Innovations team at Children and Family Futures, and most of my work revolves around supporting states to address families with substance use disorders who are at risk of or engaged with the child protective system or the child welfare system. And much of my focus really is on infants and infants who are born prenatally exposed. So we're going to talk today a little bit. I'm going to start with a little bit of data. We're going to talk about prenatal exposure issues, and then we're going to talk about intervention opportunities with families with SUDs, and particularly with pregnant women. And then talk a little bit about the child protective response and sort of what they're looking at in terms of safety and risk. Um, I work for an organization of Children, Family Futures. We are the contractor for the National Center on Substance Abuse and Child Welfare. So I am here with you representing the National Center today. We are jointly funded by the Children's Bureau within the Administration of Children and Families, and then SAMHSA, which is the Substance Abuse and Mental Health Services Administration. The views, opinions, and content of this presentation are those of the presenters, myself, and not necessarily reflect the views, opinions, and policies of ACF, SAMHSA, or the U.S. Department of Health and Human Services. Um, but the organization I work for, Children and Family Futures, we've been running the National Center since its inception in 2002, but we do a lot of other work. We work with family treatment courts across the country. We do a lot of evaluation work, and we're also the home of START. So not sure if folks are familiar with START, but Sobriety Treatment and Recovery Teams. They're an evidence-based model that pairs child protective service workers with people with lived experience. They're on the FFPSA clearinghouse now, which is very exciting. All right, but let's jump in and just talk a little bit about the need to do better for families. The statistics say that there's probably about 19 million kids under the age of 18 who are living with one or more parent with a substance use disorder, and that 85% of those who need treatment services for a substance use disorder don't actually receive them. And so we're going to look to start with at kind of what's going on with some of these kids who do end up in the child protective service system, and to understand the impact of substance use disorders there. So what we're looking at in this screen is this is based on foster care data that is reported by state child welfare departments up to the federal government, and then we're looking at it by state. And so specifically, this is looking at for kids who ended up in the foster care system. Why did they end up in the foster care system? And if at least one of the reasons why they ended up in the foster care system was because of parental alcohol or substance use, you see them reflected here on this chart. I mean, you really do see a pretty significant difference, right? With Alaska at one end at nearing 70% and Louisiana all the way on the other side, that is like barely scraping 5%. And when we look at this data, it is very misleading. And one of the issues that we're seeing here is a lack of capacity to track what's going on with these families. So the child welfare services sort of data capturing mechanisms aren't doing a great job of capturing why these kids are really going into care, particularly when it has to do with parental substance use. The states at the higher end, well, I should say when I do this in person, oftentimes I'll ask, what do you think the actual number is of these cases are that have parental substance use as an issue? And most folks, especially folks who are in child welfare, will often say it's probably like 85% or 90% of the cases that they're dealing with because of parental substance use. But when we look at the data, we really don't see that reflected. The states at the higher end, and Utah is one of them, are states that actually tend to do a better job at capturing the data. And the way they do that is that they oftentimes substance use gets categorized as neglect, and the child welfare system actually sort of force the CPS workers to take another step and sort of identify what actually is the cause of neglect. The other thing that states at the high end, and I know Alaska does a really great job of this, is that they screen every single family coming into the system for the potential of substance use. And when I say screen, I mean a verbal screen. So they're using an evidence-based tool where they're asking 4 or 5 questions about substance use to try to identify it really quickly, and then they're able to capture it in the system. So there's nothing really magic that happens when you cross the border, right, from Utah over to Nevada, even though Nevada ratas like hanging out kind of much lower. I'm trying to find them there. I think they were in the 30s when I found them the other day. But where'd they go? You guys are probably seeing it. Oh, there they are. They're way down here, and they're hanging actually under 30%. Nothing magic happening in the when we cross the border. It's really just about what's happening in the data system. So this is similar data, but it's looking at the national data and then Utah's data, and we're looking at again that same population of kids who are in out-of-home care with at least one of those reasons being parental alcohol and substance use, and we see this increasing. And that likely has to do with what we've been seeing going on with the heroin and the fentanyl epidemics. And it also likely has to do with our ability to capture that data more effectively. But we see this sort of general rise happening both nationally and in Utah. When we dig in a little bit deeper to understand who is going into out-of-home care in terms of their ages, what we see is that very young children are outpacing older kids going into the foster care system. And this is for any reason, right? So kids for any reason going into the foster care system. When I talk to CPS workers who are much more knowledgeable about this than I am, and I say, when you see these numbers of very young kids going into care, what do you think? And they say they tend to think about, again, substance use, about serious mental health issues, or about domestic violence. So we're keeping an eye on these very young kids, and they're going into out-of-home care. The next sort of question for me is like, well, what's actually then happening with these kids? And this is looking at families where there was a termination of parental rights that happened. And when they look at these families, they're backtracking and say, why did these kids initially go into out-of-home care? And what they're finding, and I've done this in like state after state after state, and it always looks like this. Neglect is the leading term or the leading reason. And again, neglect is like this basket term, right? Where it collects a lot of different reasons for the neglect. But that secondary reason that's leading, kids into out-of-home care, the end in termination, is parental alcohol and substance abuse. So we really need to do more to support these families where addiction is one of the driving reasons for terminations in the end. So let's talk a little bit about the short and long-term effects of prenatal substance exposure. There are both short and long-term effects. The AAP, and this is getting a little bit old, but they did a review of 275 different peer-reviewed articles that spanned about 40 years, from 1968 to 2006, and they looked at what was going on in terms of the identification of the exposure and the outcomes of the exposure on these kids. It's important to note that in practice, it's very rare to find a child who's exposed to only one substance. So the point isn't necessarily to compare across substances, but to point out similarities in some developmental domains and recognize that more research is needed, and also recognize that polysubstance use should be expected when we're looking at developmental outcomes. So you can get a sense of what those short-term outcomes look like for kids, where we see these strong effects related to alcohol for growth. So kids not coming with a high enough birth weight, and also anomalies. So we know sort of facial features and things like that from fetal alcohol disorder. We also see strong effects from opioids. I know we're all probably aware of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. And then you'll notice for methamphetamine, there's still a lack of data in terms of the short-term effects on infants. You'll see the long-term effects here. We know that alcohol, right, is one of the leading substances that lead to developmental disabilities long term. So these are things that can't be sort of fixed, they can be supported. And then opioids, we're not seeing that same sort of level of strong effect in terms of long-term outcomes. Um, Again, this is really like a complex interplay of factors when we're looking at two kids that maybe have had similar exposure and then had very different outcomes after the birth. So there's a lot of different factors that affect what happens to kids after birth related to that exposure. Genetics and family characteristics, access to prenatal care has had a really strong positive influence on outcomes to kids, whether they're substance exposed or not, what's happening in terms of parent-child bonding, and of course, things like the type and level of substance exposure. So I want to talk a little bit about how we're supporting these families with substance use disorders. When we do work with states, we often use this model, which we call the 5 points of intervention. Really, basically, it's the idea is that there's 5 points in time when a system can identify that a pregnant woman is using substances and can intervene and sort of engage with that family to lessen negative outcomes in the future. And so those points in times are the pre-pregnancy period of time, prenatal, birth, the neonatal period, and then the child in adolescence. So I want to spend a little bit of time digging into those and talking about some practices around each of those periods of time to identify and to support these families. And the first one is the pre-pregnancy period. So I think we're all familiar with these public awareness campaigns about drinking during pregnancy and how that can be negative in the long term. Ideally, this is an opportunity to educate women before they get pregnant about the dangers of use during pregnancy, and sort of the idea of lessening use, moving into recovery before getting pregnant, where that's possible. The other opportunity is to have physicians screen sort of all women that they're working with who are childbearing age, or really just all women for potential substance use disorders. And I think we've all like been to the doctor and they oftentimes ask that question about like how many drinks do you have per week and like have you used any illicit substances? But there's actually other evidence-based tools that they can use. Again, they're short, verbal, 4 or 5 questions that they can integrate into their intake work that may like lead to better outcomes in terms of identifying a need for substance use services or further assessment. So I think the big examples are these are the 4 Ps plus or the 4 Ps and 5 Ps. So it's 4 questions. It's about things like their partner and their family and their past use of substances. If we don't identify substance use during that pre-pregnancy period, then the next opportunity is during the pregnancy period of time. And again, we really like to encourage physicians to use screening tools during pregnancy. So integrating pregnancy, specifically tools developed for use during pregnancy, again, so the 4 Ps and the 5 Ps, and to have these conversations about substance use disorders. Oftentimes, physicians have a lot of anxiety about asking these questions. They don't know what to do if that person screens positive. They don't know how to fund the time that they're asking, or they don't have time to do it. But these really can be a starting point to have that conversation and to find those supports for that pregnant women. If you have a mom who's using medications for opioid use with disorders, so things like methadone or Suboxone, this is an opportunity for that physician to develop a relationship with the prescriber of MOUDs. Oftentimes, there's a real sort of silo happening between these two providers. So even things like have there been dose changes? Has mom been showing up? Has there been a relapse? I mean, these are things that shared, if we're approaching that mom in sort of a non-stigmatizing way, that can be, we can create that safety net together and provide those supports and structures for her. It's important that MOUD providers educate pregnant women on the risk of neonatal abstinence syndrome or NOWS. Sometimes women still show up to deliver and are unaware that that infant might have to be in the hospital for a couple of weeks or even sometimes 6 weeks if we're not using Eat, Sleep, Console. So making sure that she understands she's doing the right thing for the infant, the infant still may experience withdrawal. And again, just how do we get together those MOUD providers and those OBGYNs to join the treatment team and to have some conversations about mom and how we can support mom together? So I talked a little bit about this, but there's a lot of these barriers to screening for providers. So for the patient themselves, they're worried about disclosing. They're worried about that fear of discrimination. They're worried about that CPS call. So whatever we can do to have these conversations with them during pregnancy to sort of lessen the potential that there needs to be a call at the birth event. But I've had providers say to me, I don't have to screen because my patients don't use drugs. I'm like, well, if you're not asking them, like, how do we actually know that? that they don't have time, they're worried about the payment, and they don't know what to do if they screen positive. And this is like these are legitimate issues. I come from the substance use world. We don't always make it super easy for that referral process to happen. So again, how do we build a collaboration into our communities so that that healthcare provider knows how to bridge that gap and get that client into treatment as quickly as possible? I'm sure you guys have lots of information about medications for opioid use disorder. You can see on the screen the benefits related to opioid use disorder. So we know that it reduces opioid use. We know that people who are taking methadone or Suboxone stay in treatment longer, right? Which we know longer dosages of treatment lead to better outcomes. Most importantly, it reduces the risk of overdose and it reduces the risk of death. So we really push these medications for the safety of the clients that we're working with. And because it creates sort of this more consistent move towards recovery, it really lessens healthcare usage and treatment costs overall. For pregnant women in particular, there are two medications that are recommended for use, methadone and buprenorphine. Both of them can really help pregnant women to reach and maintain recovery and prevent that return to use and relapse. It's also shown that women who use buprenorphine have a lower risk of adverse neonatal outcomes than methadone. So we're seeing some preference for buprenorphine over methadone. Buprenorphine can also result in infants requiring less morphine, a shorter hospital stay, and a shorter duration of treatment for neonatal abstinence syndrome. So lots of positives coming out about the use of buprenorphine during pregnancy. The other thing to think about with pregnancy and with MOUD is if a mom is in active use and she's using opioids, 5, 6, 7 times a day, she's experiencing this high and then this crash and this high and this crash and the experience of withdrawal sort of over and over. And as she experiences that, so does the fetus, right? As the fetus is trying to develop. And so when we use an MOUD and create that sort of stable platform that not only benefits the mom in terms of she's not going to return to use and that risky behavior, but it also benefits the infant's development because they're not in those experiencing those stressors of that sort of boom and crash of use. So we've been through the pre-pregnancy period. We've been through the pregnancy period. Say we don't catch substance use during pregnancy. The next opportunity is the birth event. During the birth event, we hear a lot about toxicology testing. So we have the opportunity to toxicologically test the mom and also the infant. Important to note that that tox test may show us a positive result. That doesn't necessarily tell us what it means about the mom's level of addiction or need, which is why we still say verbally screen. We need to get our providers having conversations with their pregnant women patients about the potential of substance use, right? We need to bravely walk into these conversations with the clients that we're serving. Really important for this population too that we identify a pediatrician before hospital discharge so we can make sure that that continuum is nice and smooth and mom and baby show up for those pediatric appointments. And then for infants who are experiencing that withdrawal syndrome, we've seen a lot of study has gone into the use of non-pharmacological treatments. So beyond treating that infant with morphine, we're finding things like skin-to-skin contact and breastfeeding are really helping those kids move through the withdrawal faster. And I'll talk more about that in a moment. In terms of what's going on with these kids when they're experiencing neonatal abstinence syndrome. So NAS is sort of more of an umbrella term. You can experience an abstinence syndrome from opioids, but also potentially from alcohol, right? And also from benzodiazepines. NOWS is specifically related to the exposure to opioids. And typical symptoms that we see are, what we hear about most is that severe irritability. So these kids are pretty uncomfortable and upset experiencing that withdrawal. We hear a lot of like high-pitched cries cries and an inability to soothe. They have difficulty feeding, and can have gastrointestinal issues, respiratory problems, and sometimes seizures. Um, the intervention that I was talking about, and this has been going on across the country now for about 10 years, and we're seeing many hospitals moving towards this model, which is eat, sleep, console. And it's recognizing really the need for these kids to be with that sort of primary caretaker and really focusing on whether they can eat, how comfortably they can sleep, and how consolable they are. And really, they've done really amazing work. They've drastically reduced the period of time that kids are staying in NICUs, and by really integrating a primary caretaker to be with these kids all the time. So they are held and swaddled and breastfed and like sort of contained with that caregiver. And this was really a big change for a lot of hospitals. Parents had a lot of anxiety about coming in because they kind of felt like they were labeled the addict mom, and didn't feel good on the NICU floors and felt a lot of judgment. And then the nurses and doctors serving the families had a lot of concern about the parent and their capacity to show up and to be there, and to be in a headspace, like to be clean and sober and capable of taking care of that kid. So there needed to be some work, right, to develop some trust sort of on both sides to be able to integrate the parents into the care. Not all parents were ready to do that, and so a lot of hospitals have hired a lot of volunteer cuddlers that come in and take the place of mom. But where possible, they've really worked hard to get moms and dads integrated into the treatment of NOWs and have really seen positive results. And there's lots been written about this. If this is unfamiliar to you, that we'd be happy to send you. Okay, so now we've sort of birthed the baby. The next opportunity for identification is that neonatal period. And so we often talk about the neonatal period as a fourth trimester. And the difficult piece of the fourth trimester is that we really see services fall away during this period of time, right? Mom was going in to see the doctor every week, and maybe she had a home visitor, right? Maybe she was part of like NFP, or like all that home visiting stuff was happening. And then a lot of that stuff goes away like pretty soon after the baby's born. And this can be a really dicey time for moms. So I think first piece is to really make sure parents are educated and caregivers about what to expect after delivery and how to support the infant. Because if an infant has gone through that withdrawal process through the hospital and is ready to go home, it doesn't mean that they're not going to still be sort of finicky or have a hard time self-soothing. So there's still that work to be done. So making sure that folks are ready to take that on. Really important that we're making sure that for kids that we know have any kind of exposure, that they receive a referral over to early intervention services. So these are called different things. They're the child development centers, IDEA Part C funded supports that are screening kids for potential developmental delays and then, right, engaging them in the supportive service. It can be difficult with infants because when they're first born, they're basically too young to show any kind of delay. So it's important when we identify these kids at birth. Oftentimes they might get sort of rejected from the IDEA Part C systems, but that we are tracking them so that we can send them back in for re-referral. Because if we don't do that, what happens is they tend to pop up at school age, right? Maybe second or third grade is when we see them. So how can we make sure to sort of stay on top of that, when we know that there's been any kind of exposure? We also just want to think about where are those discharge plans going, that they're not just sort of going out into the universe and nobody's seeing them again. Again, like I was a substance use disorder treatment provider. I worked in a 6-month program with pregnant and parenting women. It was really great for me to get the information from the hospital, so I knew what they were recommending for the mom and kid and mom and dad, so that I can help with like shepherding that through and sort of case managing that. So wherever we can, again, get that appropriate consent, share that information so that we're supporting that parent across systems. After the birth event, when we're talking about kids who have been born exposed to substances, actually a federal law that says that an infant born affected by substance abuse, withdrawal, or fetal alcohol spectrum disorder needs to have something called a plan of safe care. The plan of safe care, the intention of the plan of safe care is that it is a family plan that supports both the caregiver and the child. And so there's a specific regulation in the law that says that healthcare providers have to notify Child Protective Services of these infants when they're born. And a notification is different than a report, and it may look different. It looks different state to state. Oftentimes, the notification is going to a community provider who develops a plan of safe care, and then the report goes to Child Protective Services if there's any safety concerns. Under federal law, the plan of safe care isn't necessarily an indication of child abuse or neglect. It's an indication that an infant was born substance exposed and that we want to make sure they're engaged and given the services they need so they don't end up in the child protective system. So you might think of an infant who's born exposed to methadone, where mom is stable and in a methadone program. There's not a need for a child protective response, but they could use some more supportive services, and that really is where the plan of safe care comes in. Some states have also found them helpful for marijuana only exposures where the cases get screened out of child protective services. They're not seeing risk factors, but something is maybe going on, so it's sort of more eyes on the family and supports through the plan of safe care. So the federal law doesn't say who has to develop the plan of safe care and who takes ownership of it. And so it really does look different in different states. But oftentimes it's like public health or substance use disorders or substance use disorder treatment. Or I worked in Washington State and they use their Help Me Grow, which is like a phone-based referral service to oversee the plans of safe care and to support those families. So plans of safe care are one sort of tool in the toolbox that can be helpful for supporting these families after the birth event. When we're preparing for hospital discharge, again, just some kind of big things to sort of keep in mind. We talked about coordinating with the pediatrician, so let's make sure we have that pediatrician identified, that first appointment scheduled. Are we talking to other folks to let them know what happened in the hospital, what's going on? So are we coordinating across the MOUD folks, the SUD people, the early identification people, other specialists that are working with this family? Have we made the referral over to early intervention services for these kiddos when they're born? And are we tracking the outcome of that and re-referring as needed? Scheduling that follow-up with the obstetric provider. And then we're thinking about the fourth trimester. We know a lot of services are falling away. Is there some parenting supports in the community that we can connect this family to ensure that they're still supported? And just worth noting that the postpartum period, again, sort of second plug for this, can be a really challenging time for people with substance use disorders. So women who use opioids during pregnancy are at increased risk of depression, anxiety, and maternal death than those not using opioids. One study showed that pregnancy-related deaths, 22% occurred during pregnancy, 25% occurred on the day of delivery or within 7 days after, and 53% occurred between 7 days after and a year after pregnancy. So it can be a dangerous time for women with substance use disorders after pregnancy. So mental health conditions accounted for 23% of deaths, including deaths to suicide, overdose poisoning, and others related to substance use disorder. So challenging time that fourth trimester when we're working with these families. And finally, like this large sort of final period of time, the fifth period, which is infancy and beyond. So again, sort of that plug for regular developmental screenings, if we have concerns about these kids, that the early intervention referrals are consistent. Again, if we don't catch that substance use during that prenatal, postnatal period of time, it's oftentimes like second or third grade when we're starting to see maybe behavioral issues or cognitive issues or something else going on that maybe then gets tracked back to parental substance use or oftentimes gets misdiagnosed, right, as something like OCD when it's actually FASD going on. So, as kids get older, we have to also start thinking about adolescent risk factors for developing a substance use disorder of their own. So, how are we engaging with those adolescents, referring them appropriately, having conversations with them about the risk of potential addiction issues on of their own? So I want to switch gears a little bit and talk about child protective services and a little bit about what they're looking for. So the data tells us that there's thousands of families impacted by substance use and involved in child welfare. We looked at some of the data at the beginning. The life of a person with a substance use disorder can be fairly chaotic and out of balance, and there's a lot of potential negative effects of that substance use can have, not only on them, but also on their friends and also on their family and their kids. So we see how substance use negatively affects family functioning across all of these different domains. So we see household safety. So that might be about parents neglecting kids' basic needs. So not enough food in the fridge and the cabinets, no adult supervision. It could be about manufacturing of substances in the home with unsafe chemicals. We see the impacts on child development. So kids may present with fetal alcohol spectrum disorder, have a history of neonatal abstinence syndrome. Infants exposed to substances can experience, again, a range of social, emotional, and behavioral effects because of the exposure. There's psychosocial impacts where kids can struggle with communication difficulties, overstimulation, or emotion regulation. And then the postnatal environment can contribute to things like insecure attachment or other social emotional concerns. Parent-child relationships might lack trust. Kids might become parentified, right? Resulting in their own feelings of anxiety and stress. Parents may lack the skills to parent because they themselves were raised by folks with substance use disorders, and so they never gained those skills as they grew up. And then we know this is an intergenerational disorder. It's an intergenerational disease. So there may be multiple generations of family that might be affected by substance use disorders, and parents might lack the basic family supports, right, to support the kids and what's going on with their family. So, how do we define a safety threat? Like, what is child welfare looking when we pick up that call and to call CPS? So, safety threats really refer to present and impending dangers to a child or insufficient caregiver protective capacities to assure the kid's protected from danger. So, they're always balancing sort of what's going on with safety, issues in the home versus the protective capacities that a family might have. So safety threats could result in serious harm to a child and are immediate problems that need to be resolved to protect a child or to prevent further harm. So in other words, safety threats happen at a specific point in time and child welfare has to act quickly to resolve those. And the life of a person with a substance use disorder is often, out of balance again. And so we could see the negative effects of use and misuse can have a really significant impact on their ability to parent and on their family and friends and the role of sort of being a parent. So we see them struggling with, when we're thinking about the kids in particular, the ability to adequately supervise if they're under the influence, right? The ability, again, to respond to what's going on with the kids. So whether it's sort of like emotional regulation stuff with the kid, maybe a parent sort of blows up when there isn't sort of a need, or even being able to respond to sort of what's going on in the moment. We talked a little bit about that ability to provide for the basic needs to that child, so a safe environment, enough food, running water, all of that kind of stuff. And the other piece is really the having, we know kids need that structured daily routine, and the use of substances by the parent is really going to kind of blow that apart and make it difficult for that parent to create that consistent process day to day. So most child welfare agencies use a lot of assessment tools, and really they are the best at determining a safety threat with a family. So always worth it if you're working with a family and you're like not completely sure to even call child welfare to get a consult with them. They have tools that they've been using for years that are sort of evidence-based to start to determine like what level of risk there is in a family and whether or not they need to intervene. But some things to think about as we're working with family is the age of the child. So obviously, very young children are much more dependent on their parents to meet their basic needs, right? So infants and little kids have a total reliance on their parents and no capacity to protect themselves. Older kids have more of an ability to protect themselves and keep themselves safe. And the older kids can communicate to other people to say, I need help, right? I'm feeling unsafe, something's going on. But each developmental stage sort of comes with its own challenges related to parental substance use and should be considered. So just for example, with infants, we might be concerned about a parent falling asleep while holding the infant or unsafe sleep practices while the parent is in active use. But in toddlers, we might be concerned about paraphernalia around the home, right? Always sticking things in their mouth. So looks different as kids age, but there's always going to be sort of a different potential threat. So for visibility of the child, we're thinking about where that child is within the community. So kids who are in the community and have more eyes on them, right? There's more of an opportunity for community members to recognize that there's something going on and to intervene or to identify a safety threat for them. Again, with those very young children who are always at home and don't have those other eyes on them, like that safety threat increases. Next is sort of the unique needs or the special needs of children in the home. So if we're thinking here about kids with developmental or physical disabilities, they may be at higher risk because they have higher needs that that parent needs to respond to. Again, if that parent has a substance use disorder, it's going to impact their ability to intervene. And then finally, the parent-child interaction. So what does it look like when that parent and child are interacting? Is that parent responsive to the child? Does the child go to the parent for comfort or advice? And just being attuned to what's happening in that parent-child dynamic. So kids specifically with prenatal substance exposure are at higher risk for placement disruption. So meaning that they're in foster care and they have to get shifted to new foster care placements due to a variety of factors. So some of it is about insufficient education to the foster parents for how to provide for these kids because again they can be like uncomfortable, they're dealing with sort of the withdrawal, they might struggle with emotion regulation, so caregivers often receive like very brief or limited training on how to care for those kids and especially kids diagnosed with fetal alcohol spectrum disorder. So they did a study or some kind of a survey and they said that about 18% of caregivers said that they felt prepared to care for those children and about 82% said they felt unprepared to care for these children. So we need to do more to help caregivers who are working with these kiddos. There's additional factors that impact the placement disruptions. Sometimes caregivers are just not informed at all about the prenatal substance exposure, particularly for older kids. We know that kids who've been exposed have really complex needs. So, for instance, infants with neonatal abstinence syndrome are highly sensitive to sensory stimuli, and they can be difficult to soothe. And children with fetal alcohol spectrum disorder can experience impulsivity, memory impairments, and difficulty with controlling emotions. So I just wanted to kind of wrap up today with like one other thought about this because we work with Child Protective Services as an SUD provider a lot and oftentimes our systems don't always work together really well. And just as another plug for that, we need to get into a room and we need to talk to each other about what's going on with these families and how our systems interact because they don't always work well together. And so this is three different clocks that we're thinking about at all times, right? And child welfare is really dictated by the Adoption and Safe Families Act or ASFA, and they have a timeline for permanency. And so permanency might be with mom and dad, or permanency might be about termination of rights and going into foster care. But they're thinking in a 12-month cycle about what's going on with this kid and where this kid is going on. So 12-month clock. And where we have that, which is really not in line with child development, which is moving really fast, right? Every day that infant's brain is developing at a rapid speed and changing, and that's going to be going on for the rest of their life. which is also very different than treatment and recovery, right? So we talk about treatment and recovery as being sort of one day at a time for the rest of your life. We also talk a lot with treatment with clients where we say, relapse is a part of recovery. Well, relapse is a part of recovery, but if you have 12 months to sort of get it right, otherwise you're looking at a change in permanency and adoption, those two things really don't work well together, right? So it's really important for us to be clear with the clients that we're working with who have substance use disorders and are involved with Child Protective Services about the 12-month timetable. We also have to hold at the same time that relapse is a part of recovery. So how can we keep sort of that momentum moving to be able to get the best outcome possible for these families? It's difficult work, it's complex work. And the systems don't always make it easy. So again, how we need to work together to sort of solve these issues. So just some thoughts about sort of taking action. If anything I said today, like got your gears turning, implement a verbal screening tool. That would be my first thing. If you're working in any kind of home visiting or medical or kind of intervention focused work, can you start having conversations about the potential that that parent that you're working with has a substance use disorder, so you can get sort of the ball rolling to get that person help. Do you have clear communication pathways to SUD treatment and back and forth? So, do you know how to get a consent sign? Do you know what kind of consent SUD treatment needs? Are you having regular conversations about how to get somebody assessed? So, have conversations, visit treatment facilities, kind of go back and forth, start building those relationships. We talked a lot about the early intervention referrals. So let's make sure those early intervention referrals are happening routinely with these kids and that there's some kind of a mechanism put in place for follow-up. And then finally, do you have who should be on your team when you're working with these families? Like who's out there in the community that you are not talking to that you should be? Who are the families that you're serving? Who are the other providers that they're engaging with, and how can we all come together to support them? So I'm sure you'll get this slide deck. I know Leo has it, and there's information at the back about how to contact us at the National Center. We have been working with states around these issues for years. I always say, don't reinvent the wheel. We probably have a version of whatever you're looking for. So reach out to us. We're always happy to support you. We also offer tutorials. So if you're like, I need to know more about substance use disorder, or I need to know more about the child welfare process, we have all that for you. It comes with CEUs. You can stop and start. It's like super easy to use. And we just have lots of other information. So if you're like, what is this collaboration that this Jill woman keeps talking about? We have lots of information on like how to start doing that.
Hey, thank you so much, Jill. That was a really great presentation. I honestly I love the point that you brought up about how, there's just these really big silos between certain professionals or certain providers and how we can just get, rid of those silos or how we can, just not be siloed. So I really like that because a lot of the times that point does come up where, providers just maybe they don't talk to each other because they don't see them. They might not see their work intersecting with each other, but little do they know that it may heavily intersect. So I really appreciate you bringing up that point. And now we
Yeah.
can open it. Mhm.
Sometimes it's so much about trust too. Sometimes I'll go into a community and I'll talk to a bunch of substance use disorders and they're holding on to a case that happened 7 years ago that they're just so mad about child welfare. And that just like impacts, the trusting relationship back and forth. And it's on both sides and we all do that stuff. So we need to get into a room and start having those conversations. And sometimes it's just about not knowing what's out there. I remember being earlier in my career as a substance use disorder treatment counselor and I just didn't realize like how great home visiting was. And then I figured out what they do and it was like I want you to work with every client that I have so like and we really started to team to support those families.
And then I also see that Tiffany has her hand raised if you'd like to contribute as well.
I would. So I have a question. We went through the foster care system for three kiddos that were exposed to drugs. And we um, had a great experience with the foster care system. Every single one of them was well supported, and we were given awesome instructions and support. However, I had a neighbor who is going through the kinship
Mhm.
to adopt situation. And I was talking to them the other day. Some of the kiddos that they got were older, not just starting at infant or toddler stage. And
Mhm.
she told me that they were finally to the adoption stage. But she knew nothing about foster care, about courses that
Mhm.
she could take. Is that,
Yeah.
I mean, I would assume that that's the same, right? They should still have that same support
Yes.
and that same. So how do I help her get connected? Do I just call? Who do I call?
Yeah, so I would probably start with the regional contact, so like the county child welfare folks or
Okay.
like the adoption units, like because
Mm-hmm.
they should have those kinds of resources. But it really one of the things about this the child welfare system broadly across the country is that it really is itself even very broken up, right? Some of it becomes very dependent on like the worker that you end up having or the unit that you're in, right? And like
Mm-hmm.
some units are very good at it and know about every resources, and others are just swamped and just trying to keep their head above water. So I think I would start with the local folks and see if there is some way to get in there. And then I would look outside of specifically the sort of this adoption system to see if there's local community resources. And certainly there's some national resources that can give you at least some information about like how to work with teenagers that are struggling with like
Right.
previous exposure and that kind of thing.
Okay.
Yeah, it can be hard.
Yeah, they're really struggling.
Yeah,
And it just surprised me that that nobody,
yeah,
informed of them, like the classes that you would take as a foster parent to be trained and ready for
yeah,
the difficulties. So I was just surprised that nobody had reached out to them yet. So that's good
yeah,
advice. I appreciate it.
yeah. In many cases, you also almost have to be an advocate yourself, right?
Right.
To get, which is unfortunate because we wish we could sort of hand deliver all of that stuff, but just the way that the system is and the stresses that it's under, sometimes the foster parents and kinship caregivers just don't get the resources that they need without being a bit of a squeaky wheel.
Okay. I'll let him know. Thank
Yeah.
you.
And then Janelle, I see you have your hand raised as well.
Yeah, Jill, great presentation. And I really loved how you kind of brought everything together. You mentioned some of the resources on your page. Do you have the five, like, I
But
can't remember what you
interventions.
called them,
Yeah.
and ways to create things so that you can connect with child welfare to show the benefits and positives of collaborating with each other, especially from a Part C system.
Yes, so we have, I don't know if it's specifically like from the Part C lens, but we do have documents specifically about the 5 points of intervention that I'd be happy to send out to you. We also have what we call the collaborative capacity series that really just talks about like how do we get together? Like what should the first meeting be? Like those kinds of
Oh,
things.
okay,
Yeah.
great. Thank you so
Mhm.
much.
Yeah. Yeah, happy to send that.
I also think that we might have one of those resources on our Project Echo website under the Additional Resources tab. It's titled Improving Early Childhood Outcomes and Systems for Families Affected by Substance Use. And it really, I read over some of them and I think they're really helpful. And they're under the Additional Resources tab at the Project Echo website under substance abuse. So I honestly think those resources are really helpful because initially you had sent them to me, I think a few months ago when we were planning this. So I really appreciate it.
Yes, we have many resources on the website. So I'm always happy to curate because I joke that we at the National Center are like a very wordy people. So sometimes it can be a little bit of a deluge to find what you're looking for. But if you tell me what you need, I'm happy to go and curate a packet for you.
Hey, thank you. That's really good to know. And I'm just going to leave a few more seconds to see if anybody has a question or maybe even a comment. You're always welcome to drop that in the chat or raise your hand so you can come off mute, or you can just come off mute since it's a bit more intimate setting right now or just smaller. And I know we did have one question in the chat, and Cami was asking, I honestly think this is really cute. I think it was when you were talking about the Eat, Sleep, Console method. They were asking, how can you volunteer to be a cuddler for those sweet babies? But maybe would you have any insight on that?
Yeah, a lot of hospitals, however you can sort of find out how to volunteer at your hospitals, that's usually one of the volunteer positions that they are recruiting for. So hospitals that have NICUs typically, sometimes there's standalone rehab units that treat infants that are going through withdrawal. So it sort of depends how your community tackles it. So either the NICU or the rehab unit, they're often looking for cuddlers. Yes, it would be a
Hey,
great volunteer position.
Right? I
that
think
would.
we're all going to go
Yeah.
volunteer for that right now because that sounds ideal.
Well, I'm not seeing any questions come up in the chat, but again, I just really want to thank you for this presentation. I really thought you brought up just some really great points for the audience that we have here today. And yeah, again, I want to thank you for those resources as well, just because a lot of the times, yeah, providers just get siloed. So I think having, sessions like this is really important so we can all know about these resources. Like, I didn't even know you could volunteer for the Eat, Sleep, Console method to help swaddle and hold those babies. So I really appreciate your presentation today. Thank you so much, Jill.
You're welcome. I'm sorry I can't stay for the case presentation, but it's been great to be with you all today. And please
No,
reach
you're
out.
good.
We love to receive, questions and TA requests. So don't hesitate to reach out with anything you need.
Hey, awesome. And that is my segue for the case presentation that I have for you guys today. Let me just put it in presenter view. Those are the instructions. I'm sorry. Okay, there we go. So again, I'm Leo Vasquez. I'm the project assistant for Project Echo. Just a bit of background on this case. I think I want to start us off with a simple question. So, when a family kind of just stops showing up at events, appointments, or conferences, even those small everyday moments, what do you assume is happening? And more importantly, what might be missing? So, today's case isn't just about a preschool, but it's about a community system that's losing connection with the people it's meant to support. Parent participation has basically quietly slipped away. And just a lot of things are happening within this preschool system or this community system. It's basically led us to have fewer conversations and interactions that help us understand what those children need. So the staff basically describe a lot of barriers that many of you actually may have seen in your own work, such as language differences between families and the providers, maybe unpredictable work schedules of the family, or maybe families who have learned that sometimes through painful experience just to not trust maybe formal medical systems or formal systems themselves. And so the impact of this is actually twofold because when families start to disengage, children actually lose that bridge between preschool and home. So goals become harder to co-create and routines just become inconsistent. So some of the primary areas of concern, it's first when families stop participating, we really we lose more than attendance. We lose that shared decision making and the relationships that help those children thrive. The second primary area of concern is that the staff are really unsure of how to rebuild trust with those families who may have had those negative experiences with schools, social services, or other systems. Even well-intended unattended outreach can feel a little risky to a family, maybe carrying that history. And third is that the program is trying to do all of this without some of those strong community partnerships that may be needed. So there's not really any cultural brokers. There's not too much translation support. I think there's only one translator, and I actually forgot to put it's more of a rural area as well. So there's just not very many resources that they think they can access. And just without those connections, engagement just becomes an uphill climb. So our goals are pretty simple. It's to first strengthen relationships with families and to expand access to community partners who can support that language and cultural need, and just to create a more welcoming environment where families feel comfortable participating. And while trying to reach those goals, we've come across those barriers of, again, limited bilingual staff and inconsistent access to interpretation, families' work schedules and transportation challenges, staff uncertainty about how to approach those families, and just few existing partnerships, again, with community organizations that reflect the families' culture and languages. And just some additional information on this case. Some families express interest in participating, but they feel unsure of how to navigate those preschool expectations, as well as navigating some of the expectations with the teacher or with some of the providers that work at the preschool. And the staff want to improve engagement, but they feel pretty stretched thin, and they honestly lack training in culturally responsive practices. So they've been trying to find more of those trainings throughout their community. So, just for community discussion, some of these questions I think those last two could probably be combined, but it's just what approaches help not just early childhood programs, but what approach have you used in your own program to create a welcoming and culturally responsive space for all families? And the second question on that community ties is how can providers just adapt communication strategies to better meet families' language, cultural, and scheduling needs? And that second portion of these community questions would be just building those supportive connections. So, what community partners could help families feel more connected and supported, and how can EI providers collaborate with those partners? And maybe what are some realistic and small steps that this program can take to help them reach those goals that they need? Okay. I think that means everybody's back. So again, I hope everyone had a really great conversation in their breakout room. I know Kurt and I did. I took notes for Kurt, so I'd actually like to share maybe a bit of what we talked about. I think a lot of what we talked about in our breakout room was just how we can increase that trust between families, because we know that there are a lot of programs here that can aid them in accessing those services, or they can just access those services. But it just does come to a point where maybe those families have that mistrust. So it's always just maybe having those conversations with the family, letting them know what's going to happen. Or even then, I think a participant bring up a really great suggestion where there's some community events where maybe a marginalized community or a member of a marginalized community may not feel very comfortable attending. So maybe even holding those events in a more private space would allow for those communities to engage better with some of these providers. And I also just want to talk about the point too that Jill was bringing up, where providers and a lot of these organizations just silo themselves. It's almost like they're unwilling to speak to each other. So I think once those lines of communication are actually open and people realize that, hey, we can actually help each other in this way, it really just opens up doors for these families. So I think it's really important. And then I don't know who else was in. Were there two breakout rooms, Janelle?
Yep. So the next one was Lisa and Tiffany.
All right.
And this is Lisa. I can go ahead and share a couple of things we talked about for our questions. We also had a really good conversation. Those breakout room times go really fast sometimes. But the first question was, what approaches help early childhood programs create welcoming, culturally responsive spaces for all families? And a point that was really driven home is that it starts with leadership. If it doesn't start at the top, it likely won't happen, and the importance of leaving biases, implicit biases at the door. If somebody says they don't have an implicit bias, they're not telling the truth. All of us have implicit biases. So it's really important to leave those at the door. And then really quickly, how can providers adapt communication strategies to better meet families' language, cultural, and scheduling needs? And a thought that we came up with is having different means of communication available. So whether that's email, text, phone calls, and asking the family their preference for what they prefer, how they want to be communicated with, as well as for dual language families, ask their preference of what language they want to be communicated in. Don't just assume that they may want to have you speaking a certain language when you're trying to communicate with them, and really work hard to empower parents, no matter what the intended outcome is, because gaining that confidence will help support them in participating in various opportunities with their children.
Those sound like some really great suggestions. I honestly really appreciate too how a lot of them were very family led. Like we should be asking the families, "Hey, what's your preference?" And I really think sometimes maybe providers might forget that, but I think it's really good just that family engagement portion of everything. So, I guess that is the end of our case presentation and I guess the end of our session. But just a few reminders. If you'd like to present a case presentation for the substance use echo, you can always email projectscope@usu.edu. And it doesn't always have to be you presenting. We could always set it up where one of our team members actually presents a case for you if you're not really comfortable presenting to the group. But again, we always really love hearing from our participants and just hearing about all these different cases so we can get those suggestions out there. So if you'd like to, again, email projectscope@usu.edu. And with that same email, you can also email that email to access the Canvas page where we post additional resources from the presenter slides, and also this recording and past recordings from this echo. And our next upcoming session is going to be on June 10th at 12 p.m., same time, same place. And we'll be having Frank Bedolla presenting on the cognitive behavioral approach, and he is actually from the Fathers and Families Coalition. So we're super excited to hear from him. Thank you.